Thank you for that introduction and for the chance to be here tonight. I've got quite a few slides to share with you that will tell you about the project that we're undergoing right now. If you've been in the Cottage neighborhood lately, you know that we're underway now, and so we've been at this since our groundbreaking last August. But I'd like to start by sharing with you a number of things by way of background for Cottage, and begin by just going back to our roots. Cottage is actually a very old organization by California standards. It was founded by 50 women here in 1888 who saw a need for a hospital. There were only 5,000 people here in Santa Barbara at the time, and they decided it was time to build a hospital. So they had this concept of building 6 cottages. There was going to be a medical cottage and a surgical cottage and so on, and their fundraising fell a little short, and they went back to the drawing board and decided to build a single 3.5-story wooden structure that you see here. And this hospital opened on December 8th of 1891 as the town's first hospital. And it was actually a very modern facility. In 1891, the Morning Press, the newspaper at the time, had this to say about it: no more complete healthcare institution. All of its appointments exist anywhere in our state. Closets in every room, and in each of the 2 stories is one containing a fire hose, all ready for use. So this is what defined a modern hospital in 1891, and we've come a long way in healthcare, not just here in Santa Barbara, but around the world for what we consider to be modern medicine here in 2006. Cottage today is actually 3 hospitals, as was mentioned. Santa Barbara is the oldest of the 3. We've affiliated with Goleta Valley Cottage Hospital and Santa Ynez in 95 and 96 of the 10 or 11 years ago. And what a lot of people don't recognize is that there's a children's hospital within the walls of Santa Barbara Cottage Hospital. We have a very extensive array of pediatric subspecialty programs at Cottage, and these are the only pediatric programs between Los Angeles and the Bay Area. And so we have about 40 patients at any given time who are in one of those pediatric units. One of the things that's unusual about Cottage that I'd like to share with you is its broad scope of services. It's very unusual to have a hospital in a community of 200,000 people that has this level of specialization. We've just listed some of the programs that you see here that are unique to Santa Barbara County, and many of these are the only programs of their kind, again, between LA and the Bay Area. And it's happened here for a couple of reasons. One is that this is a very attractive place for physicians to live. And if you go back to the 20s and 30s, we've had physicians from the East and the Midwest moving to Santa Barbara to the point where now Santa Barbara actually has the second highest physician per capita ratio in the state after the Stanford Palo Alto area. And that really drives the level of specialization here. We have all of the members of our medical staff are board certified in one of 19 different specialties, and we have some physicians who are triple or quadruple boarded, in fact. And because of that, we have a very sophisticated medical community, and the hospital needs to keep up with that. The other reason it's developed here in Santa Barbara is that we've always had a board. We're a nonprofit organization, and we've always had a board of directors that has felt that if there's enough clinical activity along the Central Coast to do a service well, to keep the quality high, and to provide it in a financially responsible way, then we should develop those programs. And so that, combined with the strength of the medical community, has resulted in pediatric oncology. We found about 10 years ago that there are 95 children newly diagnosed with cancer in the Tri-Counties area every year. And so we developed a pediatric hematology and oncology service so those children and their families didn't have to go to Los Angeles or the Bay Area when they go through that kind of a tragedy in their family. We have a high-risk OB program, dedicated adult oncology service, and we could really go on and on in our 19 specialties with the programs that are unique for this area. Cottage is a teaching hospital, and that's, again, very unusual for communities of this size. We have the second oldest surgical training program in the state of California, and we have residency programs in internal medicine, general surgery, and radiology. We have 47 residents who have graduated from medical school and are now going on for further training in one of these 3 specialties. And again, you typically would go to communities of 500,000 or 1 million or more before you would find a teaching hospital. We also have a level 2 trauma center for the last 6 years now. We've provided level 2 trauma center, and we actually meet all the criteria for level 1 except for having in-house specialties in anesthesia and a couple of other areas 24 hours a day, and it's really not necessary to have that in-house 24/7 because we have the ability for our physicians to be at the hospital within 15 minutes almost always before the patient arrives. There are only 3 hospitals in the country that have this broad a scope of clinical services in communities of under 500,000. Mayo Clinic in Rochester, Minnesota, Eastern Maine Medical Center, and Santa Barbara Cottage Hospital. Other than those 3, you would have to go to communities of 500,000 or more to find this level of specialization. So wanted to mention that because it's one of the reasons why we felt it was so important to rebuild this hospital and continue to support this level of specialization. Just to give you a sense of activity, we, as was mentioned, have about 20,000 inpatients admitted each year at our hospitals, an average daily census of 263 patients. The emergency department has become not just a place for our local residents to go for emergency care, but also a primary care clinic for many people who don't have a personal physician or don't have insurance. And so we've seen tremendous growth in our ER to the point where we now treat more than 60,000 patients per year in our 3 ERs. We're very surgically oriented. The surgical subspecialties are, again, quite sophisticated at Cottage, and you can see that about 3/4 of the patients who are admitted undergo some kind of a surgical procedure, and we need to then have the technology to support that. 2,700 babies, the best reason to go to a hospital to have a baby, are born at Cottage. And again, we have 658 physicians on our staff and a significant amount of volunteer support, as you can see here. I thought you might be interested in where our revenue comes from and where it goes. You can see from this slide that almost half of our income comes from Medicare. About 44% of our patients are represented by Medicare in terms of their payment sponsor, and about 33% are represented by HMO or PPO, some kind of a commercial carrier. And what is surprising to many people is the level to which we provide care for patients who are represented by Medi-Cal, for indigent care, or for the medically indigent adult program. 17% of our patients are represented by one of those payers, and that makes us a disproportionate share hospital. It means that we have a much higher percentage of patients in that category than most hospitals do. And it's because we don't have a county hospital in Santa Barbara, so that care falls to Cottage. And also we don't have a lot of large employers in Santa Barbara. There are a lot of small employers in Santa Barbara County, many of whom cannot provide health insurance for their employees, and agriculture is still our #1 industry in Santa Barbara County. And so because of that mix, we have a very high percentage of uninsured and people who qualify for Medi-Cal here in Santa Barbara. Santa Barbara County actually has the highest percentage of uninsured children of any county in the state of California because of the reasons that I mentioned. And so it's one of our challenges as providers, and really one of our social challenges here for those of us who live here. So this is where our money comes from, and this is where it goes. We're a very labor-intensive organization. About half of our expenses go to paying salary and benefits for the 2,500 employees or so who work at Cottage, and most of the rest goes to supplies and pharmaceuticals and implants that go to support the procedures that are done for patients who come to us for care. About 6% is depreciation, which is going to change as we build these new hospitals. We'll see that go up as a percentage of our total expenditures. Just in terms of economic impact, this is not just Cottage. This is our county's 6 hospitals. And you can see that the 3 Cottage hospitals, plus the Rehabilitation Institute of Santa Barbara, Lompoc Health Care District, just north of here, and Marion Medical Center in Santa Maria. These 6 hospitals represent a significant portion of the local economy. We have 6% of the jobs that are provided in the county are provided by area hospitals. 6.7% of the county's economy is represented by our hospitals. And just looking at Cottage, there's a fair amount of in-migration also. We have 15% of the patients who are treated at Santa Barbara Cottage Hospital have zip codes outside of the South Coast, actually outside of the county. About half of, another 15% reside in North County, but fully 15% come into the county for care. We have a pretty broad reach because of the level of specialization. And when you look at the construction projects that all of these hospitals will be undergoing over the next 6 years, we will be investing and spending over $1 billion in construction here in Santa Barbara County on these 5 of these 6 hospitals. The Rehabilitation Institute has already done their work. We're fortunate in having a foundation that provides support for many of our programs at the hospital, including our charity care. Our teaching program operates at a subsidy and is supported by our foundation. We have a very sophisticated medical library at the hospital, and many other programs enjoy support from the foundation. And we also find that it's important for us to support some of the not-for-profits outside of the hospital whose work really complements that, the work that is done at Cottage. For example, the neighborhood health clinics. The stronger the clinics are, the easier the burden is on the ER at the hospital. So we have provided support for the East Side Clinic. We have a terrific collaboration with City College. Our foundation provides support for 5 or 6 faculty members at City College, and that investment allowed the college to double the size of its nursing program. As you may be aware, California ranks 49th out of the 50 states in the number of registered nurses per 100,000. And so the local solutions are really going to carry the day for the state's hospitals. And because of our foundation, we've been able, again, to double the size of the local nursing program. And, of course, most of the graduates of that program do come to work at one of the Cottage hospitals. Our challenges, government reimbursement. You saw that about 2/3 of our patients are represented by a government payer of some kind, and on average, those payment sources pay the hospital about 72% of the cost of care. And so that's a significant issue for us. It's actually a significant issue for our country. This is the way that healthcare financing works. Many patients are represented by a government sponsor. The government does not pay the full cost of care. So there's a significant cost shift that goes on onto the private sector. And you might remember that 33% of our patients who are represented by an HMO or a PPO or a commercial plan of some kind, they're paying well over cost to compensate for the fact that about 2/3 of our patients have payment sources that don't pay the full cost. So it's really, it's not a sustainable system long run, but it's the system that we have right now. And we're quite fortunate at Cottage that we've been able to make it work economically, but that's not true for a lot of inner-city hospitals. I mentioned the nursing challenge. That's an ongoing challenge for us. The next bullet has to do with the fact that we as a local employer have many of the same cost challenges that other employers have. Workers' compensation costs, group health costs for our employees continue to go up. In addition, we're seeing pharmaceutical costs going up at 15 to 17% per year, and so that's just a trend that is difficult to manage. But if you look at the changes in drugs, the good news is there are always new drugs coming out that are very good for patient care. If you look at our formulary and the top 10 drugs that are ordered by our medical staff and go back even 5 years, 8 of those would not have been on the formulary. 8 of the top 10 would not have been on the formulary just 5 or 6 years ago. So that R&D that's going on in the pharmaceutical industry has a very good outcome in terms of its impact on patient care, and it's terribly expensive for all of us to support that. And the same is true for technology. Because of the level of medical sophistication that we have, we need to keep up with state-of-the-art technology, and those costs are quite significant and represent a challenge for us. Seismic compliance we'll come back to in just a moment as I describe our building program. And housing is a significant problem for all of us who live here. Now that the median home price is $1.2 million, it's become the most difficult challenge for the recruitment and retention of highly competent, qualified workforce. And so we have had a mortgage assistance program at the hospital for about 18 years now that's provided very low interest second trust deed support. About 200 employees over the years have purchased homes through a mortgage assistance program, but it's not enough anymore. We're not able to provide loans that are large enough to keep up with the growth or the appreciation of homes. So we do have a proposal to build additional homes for sale to our employees, and you might have read about the project that we have proposed for the former St. Francis Medical Center site. And this is just a photograph of St. Francis Medical Center. Our proposal that we have into the city now would result in the construction of 115 townhomes, 70% of which would be sold at what's called workforce affordable rates. This means that a 1,000 to 1,200 square foot townhome would be sold anywhere between $240,000 up to nearly $400,000, depending on income for a family. And that would range, incomes would range between $60,000 and $120,000 per year for household income. And then our employees would be able to own these, and then their appreciation would be restricted to, it would go up according to the average median income of the county. And then when the employee no longer worked at the hospital, within 6 to 12 months, they'd have to sell it back to the next employee in line for these units. So we think it's a very good model. We've actually followed a lot of the work that universities and colleges have done. Very few hospitals have done this, but a lot of universities, including here at UC Santa Barbara, where there's faculty housing and ongoing efforts to address the housing issue here in Santa Barbara. This particular photo shows a before and after, and we of course have the photo from the county courthouse of the before and an animated version of the after, but we're hopeful that the city of Santa Barbara will approve this and will be able to provide the solution for some of our employees. We are rebuilding the hospital at Goleta Valley, and this is just one of the many sketches we're looking at right now to replace Goleta Valley Cottage Hospital with about a 50-bed hospital replacement. And our thoughts are for this hospital to be focused on predictable surgical cases primarily. We think this could be a very efficient campus for physicians who can do back-to-back elective procedures and try to separate that activity from the activity at the Santa Barbara campus, where we have long neurosurgical cases and trauma that comes in and kind of disrupts the operating room schedule. So our plan is to build a very efficient campus here that really supports our physician and community needs, and we envision this being a significant campus for minimally invasive surgery and robotic surgery as well. At Santa Ynez, we also need to comply with a seismic legislation, and so we'll be adding on to the Santa Ynez campus, which is located in Solvang, and also doing some retrofitting work at Santa Ynez. The Goleta project, we believe, will cost about $85 million. The Santa Ynez project will be about $10 million, and we'll focus the rest of our time on the one that will cost the most, and that's the replacement of Santa Barbara Cottage Hospital. To introduce this, I want to mention to you what started all of this. It was really earthquake activity that started the ball rolling on this replacement project. As you look at this slide, on the left-hand side, we have a chronology that starts in 1972 when there was a major earthquake in Sylmar in the San Fernando Valley. It destroyed parts of some hospitals and all of other hospitals at the time. And the state responded by creating a new agency, the Office of Statewide Health Planning and Development, and started really ramping up its structural requirements for hospitals. There was additional legislation in '83 after another earthquake, and then after the Northridge earthquake in 1994, there was a significant piece of legislation, Senate Bill 1953, that, again, improved the structural requirements for hospitals, but importantly, there was a fundamental change. All of the legislation before '94 only applied to new construction, and existing buildings were grandfathered in. The change in '94 is that not just new construction has to comply with new seismic codes, but existing hospital buildings also have to comply with new seismic codes. If you choose to retrofit to meet the new seismic standards, we had until 2008 to accomplish that work. If we choose to replace the buildings, we're given an additional 5 years till 2013 to accomplish that. And the other important finding here is that if you choose to retrofit your buildings, you have to go ahead and replace them by the year 2030. And so for us, it just made a lot more sense to go ahead and replace Santa Barbara Cottage Hospital at this point in time. In order to retrofit Cottage, it would have taken over $160 million of investment. If you've seen the Cottage campus, it would look very much at the end of the project as it looks today. We have buildings that date back to 1929 in which we are still providing inpatient care. And it would have been a 14-year project because we have these services that are the only ones between Stanford and UCLA, and we have to provide that care at all times during the project. So the dominoes that were involved with a retrofit would have taken 14 years, and about the time we finished, we would have been designing the new hospital for the year 2030. So it just made more sense to go ahead and replace the hospital now. And so we looked at a number of sites for the project. We looked at Earl Warren Showgrounds. We looked at land in Goleta along Calle Real. We looked at the Goleta Valley Cottage Hospital site. And it really made more sense to reinvest in the current campus for a couple of reasons. First of all, the current location, as we look at demographic projections, will continue to be the center of the South Coast community for the next 20 years as we look out. And secondly, if we were to move to a new location, not only would we have to replace the inpatient areas, we would have to replace all of the buildings. And it would have cost a little over $100 million more to go to a new site. And that does not include replacing all of the medical infrastructure that exists around the current Santa Barbara Cottage Hospital. The Cancer Center, Sansom Santa Barbara Medical Foundation Clinic, all the physician offices, many nonprofits in the area would have over time moved to a new location also. So for the community, it really would have been significantly more expensive. And so we focused in on our current location. As we began the design process, the fundamental questions are how many beds do you need to build, and how much space do you need to meet the needs for the next generation. And so it's interesting, if you look at the bed demand, today's hospitals actually require fewer beds to provide the same service than they did 15, 20, 25 years ago. When I first started working in hospitals about 25 years ago, the average length of stay for a patient was 8.5 days. Your typical stay in the hospital would be a little over a week. Today, for those same conditions, the average length of stay is right at 4.0 days. So we need, for the same type of patient, we need about half as many beds today as we needed 25 years ago. Also, there's a significant shift from inpatient to outpatient care. We're now doing spine surgery as an outpatient basis. And so even 3 or 4 years ago, patients who would have been admitted for 3 or 4 days are now treated as outpatients and actually convalesce much more quickly because they're able to ambulate more quickly and get back to their jobs and their lives. It's also interesting that most hospitals that are vintage hospitals have semi-private rooms and wards, which is very inefficient. At Cottage, only 35% of our beds are in private rooms, so the chances are that you will share a room with somebody else if you're admitted at Cottage, and that's very inefficient. If we have a patient who needs to be in isolation, we can't use the other bed. If we have more men than women or more women than men on the orthopedic floor, we start running out of beds because of the gender mix issue. So as we replace this hospital, we will do what almost every hospital is doing now, and that's building a hospital with 100% private rooms. And because of that inefficiency, we can actually build fewer beds than we would otherwise build by going to all private rooms. So how big a hospital will we build? Well, if you look at the bed demand, we've had counteracting forces over the last 15 or 16 years. And you can see that the average daily census, the average number of patients in a bed at Cottage, has been pretty stable, right between 200 and 225. And even though the community has grown and more patients have been admitted, we have seen a shorter length of stay. So there's a faster turnaround of patients, but in terms of the number of beds we need, it's about the same over the last 15 years. And so now we have about 220 patients on average, and we're building 343 all-private rooms for the future, which will take care of this community for the next 20 or 30 years without adding any additional beds. Now, on the space side, we have a lot of needs to increase the amount of space that we have. Just basic codes have changed since most of our buildings were built. The room size requirements are greater than they were. The support systems and corridors. Today's hospitals separate the public and the patient corridors from service corridors, so that takes a lot more space for that. Technology. If you go back to when some of our buildings were built, they were built before computers were part of our lives, before monitors were invented, certainly before we had imaging equipment the size that we have now. And so just because of technology, there's a demand for much more space per bed than we've had in the past. And as I mentioned, we're a teaching hospital, and so we need, as you have here at UCSB, we need space for that part of our mission, for patient education, for our resident program, our graduate medical education, and for staff education as well. So as we look at designing for a new hospital, today Cottage occupies about 1,000 square feet per bed at the hospital. We took a look at university teaching hospitals that have been built in the last 5 or 6 years, and those hospitals are building out at about 2,000 square feet per bed. We looked at community non-teaching hospitals, and those are about 1,800 square feet per bed. And so we're right in the middle. We're a community non-university teaching hospital, and so we're right in the middle there at a little over 1,900 square feet per bed. So you can see that we're a little more than doubling the amount of square footage that we have, and this will support technology increase and providing patient care in a much friendlier manner. We hired architects for this project with the intent of creating a healing environment. It's important to have a hospital that has all of the technology support that any of us would expect in being admitted to a hospital, but we also feel it's very important for us to create a healing environment for taking care of perhaps the softer side of patient care as well. And so these are just some images from the architects we selected are Lee, Burkhardt, and Liu. They're based in Santa Monica, and they only do hospital architecture and really pay a lot of attention not just to the technology side but to the patient experience. Here in Santa Barbara, as we design the hospital, we also need to pay attention to Santa Barbara architecture. And so we took a look at the local tradition and have designed the hospital in the traditional Spanish colonial revival style that is emblematic of the buildings in Santa Barbara, but also we wanted to convey a sense of a modern, technologically advanced institution as well. And so in our final design, we have 3 pavilions that incorporate the Spanish colonial revival style in the pavilions themselves. But as you can see in this center glass area, there's a glassy glue that holds these pavilions together and has the sense of creating a more modern facility, but also it allows us to bring a lot of natural light into the hospital to support that healing environment that we're after. This is actually the main entrance that will be located right at Pueblo and Castillo Streets. At about the end of 2009, this part will be done. Well, let me just walk you through the challenges of building in a already existing neighborhood, in a residential neighborhood. And to orient you here, there is, let's see if there's a light pin here. There is you can see this layout. The green space on this aerial is the space that's currently occupied by Cottage Hospital buildings. And to orient, you can see the freeway 101 to the south, and then Pueblo Street coming right up on the right side of that big green block there. And so we really needed to rebuild this hospital and provide patient care at the same time. So this is one of our biggest challenges of the construction. We engaged McCarthy Construction to do pre-construction management and value engineering. As our architects were designing this hospital, we wanted a general contractor to advise us on the best ways to go about rolling this out. And we were fortunate in only having to purchase 4 properties to allow us to do this, again, more than doubling the amount of square feet that we have. So this will show you exactly how the plan rolls out. What you see here, again, is Pueblo running up along the right side here. And the buildings in the upper right quadrant of the site plan here are buildings that represent the current Cottage Hospital. And this big block on the lower left side is the current parking structure. Everything on that block has to be taken down before we can begin construction of the new hospital. And so the first phases of the project will include the construction of a new parking structure on the corner of Pueblo and Castillo. You'll see that in just a moment. And also, we have to build a new power plant. We're calling it our energy center. But because we never have fewer beds in service and all of our ancillary services are in operation throughout this 6-year project, we have to have utilities that support all the current buildings and can run lines over to the new construction as well. Because the phasing here is such, as you'll see, that we'll be building some, occupying it, tearing some down, building some, occupying it, tearing some down. And so the first parts of the project are parking support and the building of a new energy center on the corner of Bath and Junipero. And when that is done, and that'll be about April of 2007, then we will finish that construction, and then we'll tear everything down on this major block toward the freeway. And in summer of 2007 through the end of 2009, we will create this. That was about 2.5 years you saw go by there. And we'll build the first 2 of 3 patient pavilions. We'll build our diagnostic and therapeutic wing. The main entrance will also be built at that time. In the diagnostic and therapeutic wing, we have all of our new operating rooms, all designed with both wired and wireless technology, and all capable of implementing robotic surgical and minimally invasive approaches as well. We'll have a new radiology department, new cardiac catheterization labs at this time, a new definitive observation unit that allows us to admit patients and observe them and assess whether they needed to be admitted to the hospital or whether they can be managed on an outpatient basis. Again, this part of the project will take us through 2009, and at that time we will occupy this. We'll occupy the main entrance, these 2 pavilions, and then we will tear down the next series of buildings and replace those with the 3rd nursing pavilion. This will take us until 2012, and this part of the project includes also a doubling of the size and capacity of the emergency department. This is something that hospitals have missed across the country time and time again. If you look at Cottage Hospital today, the emergency department at Cottage was designed in the early 80s when Cottage was treating about 12,000 patients per year. And we designed it to treat 25,000 patients. And today we're treating 42,000 patients per year in that ER. As we've done site visits all over the country, that's one that almost every new hospital had missed. And so, again, we're designing this for 80,000 annual visits and doubling its size and its capacity as well. This part of the project will also include an educational conferencing center. We'll have a theater-style auditorium to support our medical education program, and conference rooms to support the teaching services that we provide. In the new hospital, you can see also that we have a helipad. We do not currently have helicopter landing capability at Cottage, and so when there is a severe injury in the backcountry of Santa Barbara County or the need to transport someone from another hospital by helicopter, we land either at Goleta Valley Cottage Hospital or at Earl Warren Showgrounds or at the airport. and then move the patient into a ground ambulance, and that adds sometimes 20 to 30 minutes for a trauma patient, which really is not good. We really need to get these patients to an operating room or an emergency department as quickly as possible. So at the end of '09, we'll have a helicopter service available for that in conjunction with our trauma center. Parking is a serious challenge for us, probably for all of us here in Santa Barbara. And so when our parking structures are done, we're building 2 of them, we'll have 400 spaces more than we had before the project started. And we believe that that'll meet our needs for a long time. We're also implementing a transportation demand program that wherein we will pay employees $75 a month to not park in the structures. And we're adding, if we're successful in building the housing program at St. Francis, we'll operate a shuttle from those houses to the hospital. And we're actually building a bike shop in this first parking structure with lockers and changing facilities and stands for repairing your flat and that sort of thing, and hoping to encourage more people to use alternative forms of transportation by both providing that support and paying individuals to not park their cars at the hospital. This project, probably one of the many challenges is just the cost of the project. And what I'd like to share with you again is what our plan is for obtaining the funds necessary. This state mandate is an unfunded state mandate, and it really falls to every community to be able to rebuild their hospitals. And so what you see here are the sources of revenue for this project, which we now know will cost over $500 million. And starting at the bottom, we have hospital reserves. We've had really terrific board leadership at Cottage over the years. And 30 years ago, the board decided to fund depreciation. And so there's a depreciation reserve account that has been built up over the years that allows us to provide income from that reserve account to support a portion of the project. I mentioned the Cottage Foundation. Again, because of some decisions that were made in the early 80s, the foundation has spending limits that have allowed this foundation to grow over the years. And we have a very sophisticated group of investment management folks and also a voluntary investment committee that manages those funds. And so what was an initial bequest of $26 million has grown to $260 million over this last 20 plus years. And that allows us again to build this hospital the way it ought to be built. And we'll be spending those dollars at the very end of the project so that we can continue to grow that foundation during this period of 5 or 6 years. Long-term debt. We're again fortunate that Cottage was almost debt-free. We only had $20 million in debt for an operation that Cottage is about a $320 million a year organization, and to have only $20 million of debt gave us tremendous debt capacity to be able to fund this project. For those of you who are interested in how that works, we're able to issue tax-exempt bonds. We issued $100 million of tax-exempt bond financing in November of 2003, and we'll go to the bond market again on June 5th of 2007. For any of you who want to invest in tax-exempt bonds, these will be available June 5th of 2007. And through a very interesting financial vehicle, we've been able to lock in the interest rates, and we locked in at, I think, a week off the 20-year low on that. So we'll be paying 3.6% interest on $250 million of debt over the next 30 years. And that's a terrific foundation, financial foundation for us to be able to build this hospital on. And the last quadrant here is our community fundraising, and we do have a campaign that is very active right now. It's chaired by the cabinet's chaired by Dr. Peter McDougall and Lady Leslie Ridley Tree and Palmer Jackson and Mike Tobes are the co-chairs of this campaign, and we've been successful so far in raising a little over $40 million toward that $100 million goal. So it's I think a very robust plan, and it doesn't rely it doesn't rely too much on any one of these 4 sources. Now, where will we spend the money? This is kind of a fun slide that shows you where this money will go. And the first money went to land acquisition and design and entitlements. And then, of course, the construction will be the majority of money will go to the construction costs. We do have a $70 million equipment budget because it's, of course, important to have bricks and mortar, but if we don't have the very latest imaging equipment and robotic equipment and technology, we won't have the sophistication that we need here. And parking and site improvements, of course, are an important part of the foundation here. So if we spend too much in any one area, it will compromise the medical equipment budget. So we have a 10-year financial plan that we keep updated every single year to make sure that these sources and uses of funds are enough to allow us to implement this program. And we think it's a very good plan and have a very high level of confidence in our ability to do it. I will mention to you that one of the real challenges for us is construction costs. If you look at construction cost inflation over the last 20 years, you would look at an average of about 4% per year construction inflation, except for the last 2 years where construction inflation for hospitals has been 24%. So that we've built all that into our projections for cost on this, but we still have most of the bidding to do on this project in front of us. We've only awarded the bids for the very early parts, the energy center of about $35 million, the parking structure of about $13 million, and so most of the bidding is still in front of us. In terms of the challenge of that for us in California, because this seismic law affects every hospital in the state, that means that there are 470 hospitals going through this same pipeline in a period of about 6 years. And if you look at the number of general contractors that have California hospital construction experience, there are only 8 or 9 of them for 470 hospitals across the state. And so that there will be hospitals that aren't able to do this financially. There will be hospitals who may not be able to find a general or the necessary subcontractors to do this highly specialized kind of work. This just gives you a sense of the chronology on this. City Council approved this in April of this last year, and you can just see the milestones, and I've really already mentioned these to you. So this is what allows us to complete the third and final nursing pavilion in time to meet that state deadline of January 2013. I think one of the interesting things about this construction management project is the different ways in which one can actually contract with firms to do the work. This project has 7 major phases and about 21 subphases to it. And there's a lot of moving parts. And for some phases of the project, we'll be doing a stipulated sum bid where we'll do a competitive bid process for local contractors. Sometimes for those we'll include local and regional contractors. And for others, we'll do what's called a guaranteed maximum price contract, where we will negotiate the percent of profit and overhead that we have with the general contractor, and then they will, on our behalf, go out and entertain subcontract bids. And so there's an entire complexity to decisions that you make, not just about how big a hospital you build or how many beds you build or what technology to put into the hospital, but also how you go about negotiating for the construction when you're spending this kind of money in a very short period of time. So what will be different at the end of the day? I've mentioned quite a bit of this, so I'll go through this quickly, but we will have 100% private rooms compared to only 35% of our beds being private when we're done. We will have created a healing environment. The patient rooms were designed largely after the rooms we saw at Northwestern in Chicago, which we thought did a really excellent job of creating a room that addressed the staff needs, the patient needs, and family and visitor needs. Our rooms, for example, will have a couch along some windows that converts to a bed, and a recliner that converts to a bed, because more and more family members want to stay overnight with their spouse or loved one while they're in the hospital, and it's actually a good idea to do that. I just had that experience myself with a family member, and it's a smart thing to do. We will be able to separate the public and service corridors, as I mentioned before. Just the space that we'll have for patients, for visitors, for staff, for equipment will be significantly improved. Wired and wireless communication and data networks, we're trying to anticipate where the wireless technology is going in healthcare communication and data transfer. And so at this point, we need to plan for both wired and wireless technology. We'll double the size of our ER. We will add additional operating rooms, all of which will be able to support robotic equipment, a definitive observation unit, outpatient imaging center. Actually, on this time frame, we have included the development of an outpatient imaging center outside of the hospital. People who come for outpatient care really don't want to and shouldn't have to come into the hospital complex for care if they're coming for an MRI or a CT scan. And so this year we'll be implementing in a joint venture with radiologists and cardiologists a outpatient imaging center on Junipero and Fletcher that includes 3 Tesla strength MRI magnet. It also will include a 64-slice CT scanner. And the images that are coming out of this technology are really unbelievable for our physicians to be able to use. So that will be actually implemented by the end of this year. It's one of the very first things that we're doing. I mentioned the conference center and our educational support. Planned departmental adjacencies. When a hospital is built a decade at a time, like Cottage has been built, you wind up with departments next to each other that really don't need to be next to each other and shouldn't be. And so again, it's a very inefficient campus in that regard. For a patient who has a baby at Cottage, that baby is born in a building on one corner. Postpartum care is provided at the other corner, and if the baby is one of the 10% or so who need the neonatal intensive care unit, that's on yet a third corner. So this just allows us to build, all of our children's services will be on the top floor of the hospital, and again, for staff particularly, there'll be, departments will be next to each other where staff work closely together. The helipad I've mentioned, over 400 parking spaces. Child care center, we provide on-site child care for children of our employees. And we have about 100 employees on the waiting list at any given time. And so we're rebuilding a child care center that will double its capacity. And we hope do away with the waiting list. And bedside registration. This was another idea that we stole from Northwestern, where patients will not be, when they come into the hospital, the last thing you want to do as a patient coming to a hospital is sit through an admitting process in an admitting department. You want to get to a bed and start your treatment process. So we will be doing bedside registration and escorting patients immediately to their bed rather than channeling patients unnecessarily through an admitting department. So we really believe that when this is done, this will be one of the premier community teaching hospitals in the country. It is, we have a very sophisticated medical staff. We have a terrific nursing program with City College. We have this broad scope of clinical programs that I described, and the weak link really is the facilities. And so when this is completed in another 6 years, we think that Cottage will be one of the very best community teaching hospitals for a long, long way. And just some images here. I wanted to mention also that the bricks and mortar are important, but just as they are here at this campus, but what's a lot more important here is the faculty and staff and the programs, and that's true in a hospital as well. And so not only are we rebuilding the hospital physically, we're also looking at what clinical programs should be further developed to serve as regional centers of excellence for patients up and down the central coast of California. And so we went through this long-range planning process this last year and identified some goals that we are going to be working on over the next 6 years that will coincide with the opening of the hospital. And programs that we're taking a particularly hard look at are neurosciences, oncology, cardiology and cardiac surgery, innovations in the vascular field, Pediatrics, we think that there will be further specialization for us to develop here in pediatrics, and imaging, as I've mentioned. And we had a technology audit done by a company called SG2 that came in and told us in all of our major clinical areas, told us exactly where we were on the technology adoption curve. And so in neurology and neurosurgery, are we an innovator? Are we one of the leading community teaching hospitals? Or are we pretty much on par with the average? Or are we in fact behind a little bit and need to catch up? And so from this, we've developed a 4 to 5 year roadmap that will allow us to, and those areas that I've mentioned and some others, really differentiate this hospital from other hospitals up and down the coast. And patients today are able to choose where they go for care. We don't have as many HMOs as we had, where people are really locked into a particular hospital. And so we feel that it's important for people to be able to choose where they go for care. And of course, we at Cottage and here in Santa Barbara, we want to be the place that people choose up and down the coast for care. And by doing that, we will have the volume that allows us to, in turn, provide these services to the local community. So this is an important part of our hospital replacement project, well beyond bricks and mortar. So you can just see here that there's always been construction at Cottage over the years, and this project is certainly the largest that's been undertaken. And this first box on the upper left actually shows the last time that Cottage was replaced in its entirety, and that was 1913. And you can see the old 1888 building in the background there. And if you look to the lower right, when we're done with this hospital, it will be 2013. So it will have been exactly a century since the hospital was last replaced in its entirety. And again, we're really proud of the design, and it's a challenge for the next 6 years for us in many respects. But we think that we have the right people managing it, and really are quite excited about being able to do this for the community. Thank you for your patience and hearing this presentation. And we do have a DVD that shows you an animated walk through the hospital, but I think while that's being set up, perhaps I could take some questions.
So one of the things you said that you kept referring to was that clearly the hospital has to be rebuilt for code reasons, for keeping up with medical technology and all of that stuff. Are there any areas in which you think you're going to be able to get sort of a return on investment? In other words, parts that you're rebuilding, hoping that you're able to save a lot of money in, say, salaries or supplies or things like that?
Yes. The first one would be just the utility costs. Again, the buildings that we have now date back to 1929. They're terribly inefficient buildings from a energy standpoint. And so as we've looked at the utilities cost associated with the new hospital, they are almost exactly the same as we're spending now. And we have we're doubling the number of square feet that we have in operation. So it's a very efficient plant from that standpoint. We do think there will be some staff savings because of the adjacencies of departments. That right now it's a city block between some of our departments where staff work back and forth all the time. Also, we're seeing some jobs that we have now are moving outside of the hospital and are moving into the technology advances are replacing some positions, but it's pretty minor at this point. Voice-activated transcription, may get to a point where we can have that replace what is now a job that's done by individuals, but we're a long way from that taking place. I would say the energy efficiency would be probably the biggest bang for the buck on that one. And so we're walking right into the main entrance now, into this conservatory style structure. Again, we'll be doing bedside registration, so you'll walk in, you'll be greeted by somebody at the desk here and escorted to your assigned room, on one of the floors, and then somebody from our admitting department will join you to do the registration and intake. Just shows you the main lobby. Again, this would be located right about where Castillo Street is located right now, that closed street. There'll be a water element, a fountain here that actually flows into what we call a river of life, that is a recirculating stream that flows through the property. Water really is a healing element, and we want to create that as part of the environment. So we're now walking back along that corridor that separates the patient pavilions from the diagnostic and therapeutic wing. At this level on your right will be our dietary area, our cafeteria, and we actually will be able to have indoor-outdoor dining. One of the lead points to your question is that we're doubling the amount of green space that we have at the hospital and creating a lot of cloisters and areas for family particularly to be able to kind of get away and meditate. Again, indoor-outdoor dining from the cafeteria on this side. No one ever walks that slowly in a hospital, just so you know. So we'll just take a left turn here and come back into one of the patient pavilions. One of the challenges of this project is that in Santa Barbara, the height limit is 60 feet. Floor-to-floor construction for new hospitals is a minimum of 17 feet. So we can only go up 3 stories in Santa Barbara. And on this particular site, we're in a 100-year U.S. Army Corps of Engineers floodplain. So we couldn't go down very far either. We're actually building a $7 million storm drain that will take water from the corner of Castillo and Junipero down Oak Park Lane into Mission Creek. We'll have a number of family waiting areas off of each unit. We'll have this wood look flooring throughout the campus. If you were to walk into Northwestern right now, you would recognize a lot of this. The job, we were very impressed with what we saw at Northwestern and implemented a lot of their ideas. So we'll just close here by walking you into a patient room, and as I mentioned, there's a staff zone and a patient zone, and this little window seat area converts into a bed so you can stay overnight, and that chair there also is a recliner that turns into a twin bed, so a couple of family members are able to stay with the patient overnight. There's just a few images of the outside here. This is an overhead view of the main entrance. Again, it'll be a water element outside here, and doubling the amount of green space that we have. This clock tower is actually the elevator shaft that supports the helipad on the roof. You'll be able to drop off patients and go right into the parking structure as opposed to what we have now, which is a block away. This is looking down from Oak Park Lane between the diagnostic wing and the inpatient pavilions. And again, many areas like this where we will have benches and really the ability for family and visitors and staff also, and some of our patients to be able to enjoy Santa Barbara's outdoors. We'll have an outpatient entrance on this back side of the hospital, and again, this is our emergency department that will be doubling in size and scope, and that's our ER entrance on the back side.